Good morning. I'm very honored to present to you today. My name is David Jackson. I'm a clinical professor in maternal fetal medicine and a career-long participant at ISWAG conferences. It's hard to believe that in 1998, I was in Edinburgh, Scotland. I was very proud to accept the Young Investigator Award at that time. Now, several decades later, I'm excited to return to Scotland to discuss a primer on the neuroanatomy required for our basic and advanced neuroimaging. This is a humble and a simple presentation. It's meant to be a return to a time where form and our morphology precede anticipated function and neonatal prognosis. It really is a talk about relationships. And just as Michelangelo made a hidden relationship of neuroanatomy within his paintings, so we must now identify the relationships of neuroanatomy that is hidden within our imaging. As Aristotle said, he who sees things grow from the beginning will have the best view of them. And once anatomy is discovered, I promise you, it cannot be ignored. As our main point of reference for today's talk, we will discuss the anatomic and clinical relationships to the Septum Pellucidi, the Fornix, the Corpus Callosum, and the falx. The Septum Pellucidum is the single transparent membrane that runs as a sheet from the Corpus Callosum down to the Fornix. The structure superior is the Corpus Callosum, and is Latin for tough body, which is the commissural fibers connecting the left and right cerebral hemispheres, extending through the fenestration of the falx, which we will explore later. The Fornix, meaning arch in Latin, is actually a curved and C-shaped bundle of nerve fibers extending from the hippocampus to the mammillary body as a major tract of the limbic system, and as we will discuss later in the conference, is critical as part of the Papez circuit, which is involved in both emotion and development. The Fornix, as it extends downward, will curve behind the yellow anterior commissure and will insert into the green mammillary body. We presented several years ago that the Septum Pellucidum can be measured. It is a single membrane from the Corpus Callosum to the Fornix. The term Septae Pellucidi is the correct term for the two membranes that separate the anterior horns of the lateral ventricles and identifies the cavum septi pellucidi. The cavum septi pellucidi is one of our basic structures for identification in our neuroanatomy and in our neuroimaging because it's so easily seen in its echolucent form. However, what we're going to spend time today is discussing how each septum and septi of the Septae Pellucidi create the cavum septum pellucidum. We can measure and look at the area of the Septae Pellucidi, and using our techniques three-dimensionally, such as FlexView, TUI, and QLab, we're able to render these as our other modalities able to render the Septae Pellucidi as well. We simply need to know where to look for it. The reason why this is critical is because it's impossible to understand the development of the commissures without understanding the nature of the Septum Pellucidum. It is the Septum Pellucidum which is included in any description of the great forebrain commissures, and today we're talking primarily about the Fornix and the Corpus Callosum. You can see it curves, and then it curves downward to have a relationship with the surrounding structures. So let's take a minute to go over this. We have the Septum Pellucidum. Superiorly, we have the Corpus Callosum, and inferiorly, we have the Fornix, which is going to curve behind the anterior commissure, and this is actually the area of the columns of the fornix. The yellow structure is the location of the anterior commissure, and knowing where the septum pellucidum are will help us understand exactly where the body of the fornix is. And once we know the body of the fornix, we're able to identify where the column of the fornix will dive behind the anterior commissure. So the inferior boundary of the septae pellucidi identifies the fornix. These structures are quite complex in their curvatures as they curve upward, over, downward, and then backwards. Our basic neuroimaging, in which we do 3 axial planes, as you can see, only picks up small pieces of the corpus callosum, the septae pellucidum, and the fornix. So for us to be able to understand this, we must have more advanced technology and more advanced imaging techniques. We start by, again, looking at the septae pellucidi. That superiorly will tell us where is the corpus callosum, and will inferiorly tell us where is the fornix. In this axial view of a specimen, and in the picture next to it from Netter's Anatomy, we recognize that the fornices curve upward from the hippocampus. They actually fuse in the midline underneath the corpus callosum, and that is where you will have the body of the fornix. And then the columns of the fornix will dive downward. So look carefully at where the little blue dot is. That blue dot is identifying the columns of the fornix going up and down just behind the anterior commissure. Once we get past the point of the anterior commissure, however, the anatomy becomes even more complex. We have the columns of the fornix curving backwards to insert into the mammillary body, and also slightly outwards. Therefore, it is technically impossible to see the entire column of the fornix in one plane. You must be able to maneuver to find the curvature that is going back and outward. What we can see, however, is that the fornix and the body of the fornix is going to divide the cavum septae pellucidi into the anterior portion, and then the posterior portion is the cavum virgae. In its entirety, the structure is called cavum septae pellucidi et virgae. Approximately 80% of individuals will have the fornix crossing the cavum septae pellucidi at the mid portion. The new technologies that help us in our imaging is tractography. The tractography, once you identify where the septum pellucidum is, will then show you the inferior boundary for the fornix and the superior boundary for the corpus callosum. In this picture here, we have tractography of the fornix and the cingulate gyrus above the corpus callosum. The tractography of the fornix is very consistent and is worthy of your study as we utilize the tractography to help us understand where are these fiber tracts in our neuroimaging. One of the newest studies actually has a very elegant picture that shows the corpus callosum in red, shows the fornix in green, and then as the body, and then diving down in blue as the column, the anterior commissure in pink, and they've been identified that there is a frontal path from the fornix within the septum pellucidum. So it is not simply a membrane with no function. We are just now learning what the function of the septum pellucidum is. The columns of the fornix are actually at the base of the septum pellucidum. If you see the blue structures, those are actually the columns of the fornix going up and down at the base of the septum pellucidum and are identified on our ultrasound in this location. They cannot continue to go forward and meet our anatomic tractography. We can visualize and render the fornix with three-dimensional technique. And the identification of the fetal hippocampus and fornix has been published as a role of three-dimensional sonography, although we must be cautious as we continue to learn what we are seeing, that this may also incorporate the stria terminalis and incorporate the hippocampal sulcus. It is stated that this structure is able to be seen in 94% of fetuses from 14 to 37 weeks, so it simply requires us to look for it in the correct plane. Here we're using our QLab to identify the structure of the hippocampus, where the arrow is located, and the curvature of the fornix, where the upper arrow is located. This then can be superimposed to help better identify our understanding and can be followed all the way down to the mammillary body, but you must change your orientation and your location from the outside to the inner sagittal plane. This can be accomplished by utilizing the eye slice or TUI features of whichever machine you're using. And then you walk inward in increments of 1 millimeter or less to identify where the location of the hippocampus coming over, and then the fornix, which dives backwards and inward. Here's a video showing how new technology is able to assist us. With this FlexView technology, we are able to actually drive our image screen. We can either use a straight line, which gives us our typical images, but we can then walk that line in a curved fashion to identify the location of the hippocampal gyrus. And as we come back, the hippocampal gyrus again, which will be in this bottom location, the midline, and then on the opposite side, the hippocampal gyrus coming up, the fornix to here, but then it will dive down and backwards, so we can't see it in that plane alone. What we can do is now take the new technologies, and if you see, we actually are coming up and we're curving our view for a unique image that can be reproduced at every gestational age. We can even come up, we can go over, we can come down, and then we can finish with a circle and identify unique approaches to the anatomy, including the hippocampal gyrus, the thalami, simply by deciding which plane we want to curve our flex view in. This allows us to move up and down and then finish with the image that we're trying to identify. So if we don't get it perfect on the first pass, we can simply curve, come back down, and then move over 1 or 2 millimeters. In this situation, it allows us to develop and correlate our tractography on top of our gross specimens and our gross specimen understanding and our gross anatomy understanding as we continue to now develop more and more techniques related to our fetal imaging, where here we have a very nice hippocampal gyrus coming up. The fornix split and went a little higher and then is going to come down and back. So it cannot stay in the same plane. We must manipulate our volume and our slices to identify. Let's move on then to a very important and very common structure to identify, which is the corpus callosum. We tend to think of this simply as a C-shaped structure, but it is so much more than that. It is a very large commissure that attaches into the cortex and is responsible for so many functions and normal behavior. Early on, we've been taught that the corpus callosum starts and grows backwards. In fact, it still grows forwards a little bit and then grows backwards, but by 19 weeks has a very lush and full corpus callosum to start to identify. On tractography, on our imaging, the corpus callosum will be best seen between 22 and 24 weeks. Here's another example of our tractography helping us understand the development of the corpus callosum, starting here, and then it does grow a little forward and then backwards. And in the adult, we are going to have very lush and complex connections to the cortex. In our basic imaging, it's time to consider, at least visually, if not actually, measuring the thickness and the length of the corpus callosum as a routine. So you can identify when it looks either thin in agenesis and hypoplasia, or even when it looks thick, as was presented by Dr. Mallinger and his group, where we have a thickened corpus callosum. And in the 9 patients they presented, 1 was normal, but the others had quite severe outcomes, as in this case where there was diffuse thickening, asymmetric ventricles, and in fact a neonatal demise. So identifying that that corpus callosum was present but thickened was important. They are doing more and more studies that identify and correlate the thickness of the corpus callosum with intelligence and with behavior. Some of the newer techniques that we're working on is that we can measure the width of the corpus callosum as well as the thickness and try to correlate that with both normal and abnormal pathology. And with our 3-dimensional rendering tools, we can segment out the corpus callosum and then manipulate it in such a way that I'm hoping that we can identify the volume of the corpus callosum at different gestational ages as well. The anatomy of a child with agenesis of the corpus callosum that unfortunately was not able to survive. We have a situation where the tract of the corpus callosum here in the darker red was not able to be seen. However, the fornix in the slight green is still present. So as we look at this, we start again with trying to see where would the septum pellucidum be, which of course is absent in agenesis of the corpus callosum. And we're able to see that the fornix itself is moved laterally. So in all of our patients, we should still be looking for the fornix, even though there will be absence of the septum pellucidum and the cavum septum pellucidum. Here's an example of a child with trisomy 21. We see a partial agenesis of the corpus callosum with a characteristic upward displacement of what is described as the third ventricle, or a cystic upper displacement in the absence of the corpus callosum. My suggestion is that the roof of the third ventricle is defined by the fornix, so we must consider whether this is really an upward displacement of the ventricle, or is it that the roof of the ventricle is missing because the fornix is pushed to the side, and therefore we get the impression of an upward displacement and continuity. To finish our discussion today, we'll talk about another structure which is visible and yet in our minds sometimes invisible to our thinking, and that is the falx, which we see on every patient. We presented at our American Institute of Ultrasound and Medicine meeting that the falx is contiguous to the cranium, even in the first trimester. And if you identify the echogenic falx cerebri, that will give you a definitive mid-sagittal structure for your nuchal translucency technique. So the picture here shows there is an open space to the cranium above the choroid plexus, whereas here we have the falx all the way to the cranium in performing what I call a falx flash as you move your transducer from side to side. If you stop right at this moment and at this point, it will actually improve both identifying the tip of the nose and the intracranial translucency will become more clear. So looking for the falx in first trimester is more than academic, it's actually helpful in identifying the mid-sagittal plane. Knowing that the falx extends downward in our early second and third trimester scans helps us because finding the falx as interrupted at this point means it's interrupted by some structure, and that structure is the corpus callosum and the fornix. So identifying the interhemispheric fissure really means we're seeing the echogenicity of the falx, and that tells us that there are appropriate structures in the midbrain. Here's an example of the falx on a specimen, and we see the presence of the falx identified as the bright echogenic structure here. So what this is masking is not the corpus callosum, but what it masks is the cingulate gyrus. So if you are exactly in the midline in the sagittal plane, you will see this falx flash, and you can be sure that you will not be seeing the cingulate gyrus or the cingulate sulcus. So you must simply move a millimeter or so off to one side or the other. In the adult, the fenestration is quite clear to allow the fibers of the corpus callosum and the anterior commissure to interconnect to two cerebral hemispheres. This is also a phenomenon that you can identify, reproduce, and be consistent with as you're evaluating your patients with fetal hydrocephalus. Here's an example of the fenestration of the falx in a patient with fetal hydrocephalus. It is reproducible with our three-dimensional imaging, and it is something that I believe will have some clinical importance as we begin to understand it more. Here is the location of the falx fenestration, and you must do three-dimensional rendering to actually understand where your plane is on the axial picture compared to the falx fenestration. This is very important in progressive hydrocephalus because an increase in the falx fenestration explains the impression of communication between the ventricles in increasing fluid collection. This gives the impression of a single ventricle when in fact it is just a large fenestration in the falx and should not be confused with forms of holoprosencephaly or porencephalic cysts. When we look earlier in gestation at a baby with spina bifida producing the Chiari malformation, we are drawn to trying to identify the cerebellum and the Chiari location. But in fact, if you look carefully on your three-dimensional rendering, you will start to become adept and expert at identifying the falx fenestration as well. I believe the fenestration will be important, and we attempted to show that there are different sizes to the fenestration. But what would cause the fenestration to enlarge beyond pressure? Perhaps as we are getting better with our power Doppler for venous structures, we know that there is a very robust venous circulation within the cranium, and that compression of these veins may lead to problems with the fenestration and the falx itself. So in summary, we've come quite a long way from this paper in the 1960s that talked about an algorithm for prenatal ultrasound diagnosis of congenital CNS abnormalities. We're able to now use tractography to place our mind's eye exactly on where these tracks should be. We're able to use multiple three-dimensional and post-processing techniques such as iSlice, TUI, FlexView to see different structures in a different way than we've seen them before. As Dr. Mallinger pointed out in this very important paper on the differential diagnosis in fetuses with absent septum pellucidum, the differential for ASP, or absent septum pellucidum, includes agenesis of the corpus callosum, septo-optic dysplasia, holoprosencephaly, schizencephaly, porencephaly, the hydrocephalus, and Chiari malformations. Therefore, if you understand the septum pellucidum and absent septum pellucidum, you will also understand quite a bit of the pathology which we are expected to counsel our patients on. Some of the new techniques that are coming down that I think will be very helpful include three-dimensional printing of CNS abnormalities. So save your best data sets. A three-dimensional printer will be in your future soon, and we are going to be able to teach better by being able to hold these models in our hand and understand their orientation. So in essence, I ask that we be neuropassionate, not neurophobic. And I'd like to give a thank you to all of my virtual teachers and people who have influenced us over the years. Every one of these people have added to our understanding of CNS pathology and neuroimaging. We stand on the shoulders of giants, and I look forward to discussing this with you further during ISWAG and beyond.